With the L-MIND study coming into light, we have seen the evolution of a combination therapy, really kind of moving away from the monotherapy early on. Again, the monotherapy studies with tafasitamab did show efficacy, but the combination here with lenalidomide led to an improved outcome in these settings. So really looking at tafasitamab being infused, again, we have our weekly schedule, and then we actually go into a bi-weekly schedule, several cycles into it. With lenalidomide actually dosed on a Q20 or day 1 through 21 versus the 28-day schedule for this treatment, we had seen the actual outcomes of overall response rate and complete response rates truly go up in those patient populations. So comparable here to our PBR, and in some cases maybe even better due to side effect profile mitigation. So the combination really had an improved overall response rate, a good CR rate as well, and that longer duration, that duration of treatment really kind of alluded to the fact or the principle of continued outcomes with tafasitamab plus lenalidomide there as well. So that outcome evaluation from overall response rate and complete response rate in those transplant ineligible patients, and not only that, these patients were 72 years old and they had to actually receive two lines of therapy. So we are looking at an older patient population who may have higher comorbidities, who are seeing this overall response rate truly impact patient populations in this setting. So that follow-up period on there was about 13.2 months from the actual L-MIND study. And again, they had seen this improved overall response rate in patient populations. So with the L-MIND study, we had seen a good overall response rate of 60% with a complete response rate of about 43%. In addition, partial response was about 18%. So we saw this improved objective response and also CR and PR-based responses with therapy. So really making this a key player in that relapsed refractory diffuse large B-cell setting. So that was actually one of those key components. In effect, the other piece of this was the actually low percentage of infusion reactions. So not only patients did they have a benefit, did they have a long tolerability for a duration of response, and also for follow-up here too, but also some of their side effects were minimal. You know, looking at the comparison for who you treat for these patients as well, how that's selected really based on side effects. Again, for a lot of our patients, you know, tolerating sometimes the polatuzumab BR-based regimen, that peripheral neuropathy can be a weakness there. So we have to address those patients later on, especially if they have diabetes or again, older comorbidities as well. So we're always kind of playing off what is the best option for treatment here. So looking at this, you know, we not only have good options for complete response rates, durable response, and also overall response, let alone the CR and PR, but also the tolerability clearly was developed as well. The one thing that we actually do when we're actually addressing the L-MIND study and looking at how this will actually play into future treatments is mitigating side effects. And, you know, when we're taking a look at a combination therapy like this, the IV and the oral piece, it makes it a little bit tougher. And the reason why is we have to address side effects. Most of the side effects that were seen during the study were actually seen with the lenalidomide, and that was mostly a rash-based issue, again, some neutropenia-based issues as well, and thrombocytopenia. So from that standpoint, we've had to address how do you actually dose reduce that, and that's actually the lenalidomide piece, which leads to a dose reduction upon those side effect profiles. So we are mitigating that and actually breaking it down between the TAFA piece and the lenalidomide piece. So that's been a constant discussion across the board. And as we actually see this come into play and actually really come into the marketplace a little bit more for our patients with increased access, we'll actually be addressing a lot more of those issues upfront with treatment. The nice thing is we've been using lenalidomide in this setting as well as other disease states as well. So that's not something that's new to us in the clinical setting. When we're starting a patient on this combination therapy, it's really important to address, specifically right now in the face of COVID, right, where we want to keep patients outpatient, really remove their inpatient time period, is, you know, the neutropenia and febrile neutropenia. You know, and that's really an issue that's coming or becoming apparent more and more, is really prophylacting those patients up front. And really with the actual febrile neutropenia index in this study with the actual TAFA and also lenalidomide, it had a lower than 10% FN risk. If I'm not mistaken, it was actually about 6% in the study for L-MIND. So that makes it minimal in regards to less than that 10%, which really makes it a great option. Even more so, one of the key pieces on this was since we had an older patient population, if it was that caustic, you'd only expect to have a higher FN incidence. Here, we've actually had a lower incidence. So that's been a key discussion, and also key comparator between PBR and also this, is when we're looking at these combinations, do we have to also address, in the face of COVID, how this may actually become a determinant? So looking at neutropenia, thrombocytopenia, again, some of these can be dose-regulated, peripheral neuropathy. So there are also some, again, side effects like pneumonia and also thrombocytopenia with these patients as well, but these were actually mitigated and most likely due to lenalidomide. So we actually would just dose reduce those patients too. So really kind of looking at that evaluation, we talked about the CAR-T and PBR before, but I think, the majority of these side effects are mitigated early on, but that FN piece I thought was actually rather unique when looking at this combination, and therefore making it really a key point for those older patients when we're taking a look at the patient population selected.